Okay, we're at 9 o'clock. On that note, welcome everybody to our QLI webinar.
Oh yeah, it's
Um,
time.
we're thrilled today to present again to you. Um, some change in the seating. Steve Kershke had found an opportunity out in the regular world, and we're wishing him the best moving forward. A little bit about QLI from those of you that are new joining us. QLI, we're located in Omaha, Nebraska. We are a brain injury, spinal cord injury, chronic pain, limb loss, and stroke rehabilitation campus. If you're ever interested in a virtual tour, I'd love to arrange one. Feel free to introduce yourself to me and ask for a virtual tour. It takes about 15-20 minutes. Go ahead and this is our mission, and it's enveloped in everything that we do here at QLI. I'll let you read that. All right, now some of the housekeeping. Please use the Q&A for any questions. The CEU webinars and slides will come to you after attending for at least 55 minutes. Once you leave the webinar, a a prompt will come up for you to fill out the survey, the jot form, and hit submit, and then your CEU will be sent to you automatically. For some reason, if that pop-up doesn't occur, feel free to email us at qlibwebinars@qliomaha.com, and we will get you to the survey link. And I think with that, I'm going to turn it over to our insightful and talented speaker, Dr. Jeff Snell.
Thank you, Don. All right. Yeah, I wasn't even looking at my watch, and here we were just jabbering away. Okay. So I did, in the course of this presentation, I'm going to be talking about some specific companies and some products, and I thought it was important to include a disclaimer regarding the tech that we're going to be talking about today. I'm not selling anything. So I just want to let you know that right up front. I don't have any financial ties to any of the companies or products that we're going to be talking about, nor does QLI. I just wanted to present this information today to familiarize participants to some new and emerging technology that has the potential to impact the field of TBI diagnosis and treatment. And like a lot of the topics that I present, this is something that I was just interested in learning more about. And quite frankly, the best way to really learn something in depth is to teach it. And I learn so much more in developing these presentations. So as a result, I just wanted to pull this up and learn more about it and read some articles and share this with you. So this is what we're going to be talking about today. We're going to be a little bit more technical, I think, than a lot of our previous webinars. It's due to the topic, but what we'll be talking about is the use of biomarkers in objectively determining neurological injury. And that's been the subject of research for several years now. That science has now reached the point where there are currently FDA-approved blood biomarkers for brain injury and tests that are rapid, objective, and scalable indicators of brain injury. So we're going to be talking about biomarkers that have been recently approved for medical implementation, as well as this says you can't see the slides, just the thumbnail. I see several people that are seeing that. I'm sharing the screen, but I'm going to stop share for a second and then restart to make sure that it's sharing exactly what I want. Um, Thank you for the feedback on that. I appreciate it. Now you should be seeing the full slides, and if you are, please somebody let me know on the Q&A there. Sorry about that. So anyway, we're going to be talking about these blood biomarkers that are rapid, objective, and scalable indicators of brain injury. We're also going to talk about some of the breakthroughs that have allowed this to occur and how these tools may potentially reshape some aspects of acute care, particularly sports medicine, and then also the potential for long-term management of brain injury that may be implicated down the road. So, in talking about biomarkers, let's first talk about what is a biomarker. It's a shortening of the words biological biomarkers, which refers to a means of objectively measuring indicators of biological processes, whether these are typical or pathogenic, or to measure response to pharmacological interventions. When you go to the doctor, typically they are going to look at several biomarkers, things like blood pressure, pulse rate, respiration, temperature. These are biomarkers. If you have blood work done, when you go in for testing, they're looking at indicators of anticipated levels of the number of cells that make up your blood or components within your blood that are indicative of your state of health. Imaging as well, CT scans, PET scans, MRI, these are all giving you objective measures of physiological structure and function. They can reflect normal or typical physiological functioning, or they can reveal atypical or pathological states. So, in general, biomarkers can be classified into the categories of diagnostic, prognostic, and predictive. They can be used to assist in the diagnosis of a given state and thus provide information regarding treatment and prognosis. They can determine the likelihood of a clinical event or the state of progression of a disease process. Predictive information includes identifying which individuals are likely to benefit from a given therapeutic intervention. Now, we're going to focus today on advancements in research that have identified biomarkers that are sensitive to and indicative of neurological injury, specifically blood biomarkers that are present and detectable and are secondary to traumatic brain injury. Now, I've often talked about the fact that TBI as a medical diagnosis is such a heterogeneous condition, and diagnosis and treatment for TBI is similarly complex. The addition of the many complexities of treatment for severe TBI, such as those that we encounter at QLI, and those of you that have experienced cases involving complicated mild TBI, that which is often labeled as concussion. Those cases can be complex and full of questions as well. As a matter of fact, those are the cases that most of you are more likely to see. There are diagnostic criteria that most of you will be very familiar with that are currently used to quantify the severity of a brain injury. Measures like the Glasgow Coma Scale, how long or whether or not the individual experienced a disruption of consciousness, the length of time of post-traumatic amnesia or post-traumatic confusion. These are all things that are utilized to quantify the severity of an injury. But these measures are a very blunt instrument in terms of defining a brain injury. To put it another way, the sensitivity of these instruments is considered limited, particularly if we're talking about mild TBI or early stage injuries, and also issues associated with different populations that might confound this, such as working with elderly clients. Now, particularly difficult to quantify is mild TBI, problematic to research and treat because, again, the heterogeneous nature of brain injury. And that's actually troubling because mild brain injury makes up about 80 to 90% of traumatic brain injuries that come to the attention of medical providers. There's also the issue that you can have a severe traumatic brain injury from which you have relatively good recovery. In fact, this is the case for the majority of injuries. Or you can have a brain injury that is quantified as a mild injury from which you subsequently experience lifelong symptoms. Now, those individuals that experience that, that's only a subset of those who experience a mild brain injury or concussion, but research does indicate that 20 to 30% of individuals experience persisting symptoms that affect daily functioning for 6 months or longer after a mild TBI concussion injury. Now, since mild TBI and concussion are basically the same thing, they're synonymous from this point on, I'm just going to use the term mild TBI. I'm going to try to do that for the most part, but you'll notice I'll slip up occasionally. The pie chart you see on the left reflects typical percentages that are reported for the severity of TBI in the United States, and they clearly demonstrate that the vast majority of TBI cases in the U.S. annually are mild in nature. Now, many of the individuals did not require hospitalization, or if they did, they didn't require acute rehabilitation stay. At QLI, given the post-hospital inpatient nature of our typical client, we're working with individuals who have had very severe TBIs. We have to remind ourselves that the vast majority of cases that everyone else sees in clinics and hospitals involve these mild TBI cases. But even in cases of mild TBI, there exists a possibility of ongoing symptoms that extend beyond the quote unquote typical 3 to 6 month period, during which the majority of symptoms resolve for most clients. Now, the important distinction is that most does not mean all. The chart on the right indicates the percentages of individuals who experience the symptoms listed, and on the x-axis at the bottom, the time frame of the experience of that particular symptom. You can see that although there is, over time, a reduction in the percentages of individuals reporting a given symptom, they remain high enough to be of clinical interest in between a low of 15% and a high of over 40% of the cases. Now, data from the NIH indicate that up to 15% of individuals who experience a mild TBI demonstrate ongoing symptoms related to their injury for years. Those can be subtle or significantly limiting to an individual's functional abilities. So after mild TBI, although most individuals fully recover over time, that time frame can be lengthy, and at this point, it's difficult to predict who will experience ongoing persistent symptoms. There's a need to quantify brain injury in a manner that provides objectivity, predictive utility, and allows for greater prognostic accuracy. The primary clinical tool that's utilized in most acute treatment settings is CT, but a CT scan doesn't have the sensitivity to identify the kind of diffuse and subtle injuries that can result from a mild TBI. MRI has greater specificity for things such as diffuse axonal injury, which may or may not be present in milder injuries, but it may also not be considered to be indicated for such mild injuries. And as we will discuss, blood biomarkers can provide a useful, objective, and quantifiable evidence of physiological brain injury to further direct acute care and to provide some predictive data regarding prognosis. Now, one reason that blood biomarkers are such an emerging thing goes back to what we've talked about before. As new technologies develop that allow for greater detail and specificity in the study of biological organisms, well, those technologies allow for a more detailed look into the complex processes involved, and they give us data that didn't exist before those technological breakthroughs. The ability to detect levels of certain proteins or other blood products at a level not previously possible allows for identifying entirely new candidates for biomarkers, some of which turn out to be highly useful for specific markers of injury to different components within the brain. The specificity of such biomarkers has the potential use of identifying specific profiles of injury, for example, beyond just the indication of the injury itself. Differences between, for example, subconcussive exposure that is distinct as compared with clinically diagnosed and clearly observed concussive events. Being able to take the levels of a given biomarker as a predictor, for example, of who is likely to recover quickly as opposed to who may be more likely to develop persisting symptoms. That predictive potential is important because it helps us allocate resources in those cases where the risks are greater compared to those who are anticipated to have a good recovery. One of the issues that's been problematic in this area of research over the years is that of specificity, the degree to which a certain biomarker accurately reflects the diagnosis of interest to the exclusion of other diagnoses that may involve similar findings. Early studies evaluated the utility of protein measurement, and that has continued to be the primary direction of study at the current time. The listing that you see on this slide are those substances within the brain that have been included at one time or another as a potential assay source for looking at quantifying brain injury. This listing is actually from a comprehensive review in 2021, and it includes several substances that we are going to talk about here in this presentation today, highlighted there with the red arrows, to talk about in more detail. I'm presenting the overall list so you can get an idea of the variety of different substances that have been and continue to be evaluated for their potential ability to accurately detect and quantify the presence of brain injury. Now, in the same way that the diagnostic term brain injury covers so many different factors and outcomes, the complexity of the issue we're trying to pin down introduces a level of confounds into the process of diagnosis, of treatment, of prediction, of prognosis. And like most complicated processes, if you know a little bit about the subject, it sounds simple. From the standpoint of blood biomarkers, well, you identify a substance in the bloodstream that's indicative of a brain injury. You measure that substance from a clinical sample, and then you use that information as you need it in your clinical assessment or intervention. Now, over the past 20 years or so, there's been substantial increase in the number of blood biomarker research studies. Part of the issue why we now don't have a whole range of in-use blood biomarkers is the inherent heterogeneity of brain injury. Differences in severity, differences in mechanisms of injury, difference in anatomical location of injury. These can all influence potential assay candidates. And then there's the complexity of the brain itself, the role that all the different cellular components that make up the central nervous system contribute, and the fact that the brain is not separate from the body. It's all one unit that influences each and every part in a bidirectional manner. Also to be considered is the complications of TBI are that the clients that we serve are not a blank slate prior to that neurological insult. There are endophenotypes and comorbidities to consider that complicate the process. So again, what is needed and what can provide the most clinical utility is a measure that is sensitive, that is specific, that is accurate, and that is reliable. An ideal blood biomarker for brain injury needs to be highly sensitive while also being highly specific. You have to have a degree of sensitivity that allows for identification of the positive presence of brain injury, but does not yield positive results in cases where there is no brain injury. You also want a degree of specificity that accurately rejects those cases where there's no brain injury and minimizes the number of false positive results. Quick question that popped up. How long are biomarkers in one system? Going to be talking about that for the specific ones that we review. Thank you for the question. In addition to the sensitivity and specificity of a given test, a given biomarker for TBI needs to be highly consistent. It needs to be reproducible. It needs to give you reliability so that the same test gives you consistent and accurate results. So having something that is sensitive, specific, reliable, and accurate needs to be an objective measure. That gives you strong clinical utility, and that has multiple applications within brain injury diagnosis and treatment. One study in 2023 noted that with increased public attention being given to mild TBI, the number of lawsuits involving alleged TBI exposure has roughly tripled over the past 20 years. And that such cases can be challenging because often there is no objective evidence of brain injury in cases of mild TBI exposure. It's based on subjective symptom reporting and direct or secondary observations. Mild TBI often does not result in positive CT scan findings, and many of the symptoms associated with mild TBI overlap with other diagnoses, those such as PTSD, depression, anxiety, migraine headaches, and other conditions. Therefore, there is increasing need for objective evidence when mild TBI is at issue to answer questions such as, are these symptoms more attributable to a pre-existing or different diagnosis? And that question that must be answered, are these symptoms being reported exclusively for secondary gain? If we have an objective, accurate, and specific physiological measure that can quantify neurological insult, it helps answer some of these questions, and it can provide metrics to guide clinical interventions. There's also the hope that such data can potentially more accurately aid in determining prognosis for recovery than the metrics that we currently have. Now, historically, accuracy was present, but specificity was the main issue that limited usefulness. The greatest degree of utility of currently identified blood markers appears to be in the diagnosis and initial treatment of mild TBI, quickly identifying the presence of a neurological insult, quantifying the severity of that brain injury, and pointing direction for further clinical investigation or intervention that may or may not be needed. Basically, based on indications of severity, what further tests or interventions are indicated or can be ruled out based on the findings. It's important to note blood biomarkers do not replace conventional assessment means or current clinical practice in the diagnosis of brain injury. But these can be new tools that are promising complements to conventional assessment. The goal is to more accurately diagnose mild or early stage TBI, and specifically, as currently the case, to minimize radiation exposure and expense and healthcare costs when a scan is not needed. In addition to the FDA approved blood biomarkers we're going to talk about, with the use of mass spectroscopy, there's also metabolite and lipid signatures that correlate with injury severity and functional outcomes. So the science of diagnosing brain injury in a manner that allows for more accurate prediction and prognostication appears to be approaching. It also appears that the science of using blood injury indicators of brain injury will be most accurate when these predictions are compiled with other multiple methods and markers used in combination. That effectively is what we are doing clinically right now, but to add some objectivity to that and use that as an adjunct. Now, as mentioned before, protein-based biomarkers have been the main focus of blood-based biomarkers for over the past 20 years, easily. S100B is an early identified biomarker, a protein, that remains in use in many parts of the world. It is a protein that is associated with increased or amplified glial activation, so not neurons, but the support cells, what's traditionally been called support cells. They're actually a lot more than that, but the non-neuronal cells within your brain, the glial cells. Progression of processes that these cells can demonstrate secondary to a primary injury, and the use of this particular biomarker supports some degree of prognosis following TBI. The specific glial cells associated with the expression of S100B are astrocytes. What you see on the right side there, that box and those little vials, that is a platform that offers an assay for a wide range of different biomarkers. And this system can measure S100B in addition to those other antibody sets and assays. The usage statement on this product in the United States indicates that it is for research purposes only and is not for use in diagnostic procedures. S100B is utilized in ruling out intracranial injuries in Europe, but has not been cleared by the FDA in the United States for diagnostic use, secondary to some limitations of specificity. Those limitations include a lack of neuronal specificity, and in addition to brain injury, S100B levels are also increased in response to just general physical exertion and to polytrauma outside of the central nervous system. So it is not exclusive to neuronal or glial trauma. There's also been some degree of lack of agreement among what are considered to be normal values based on a variety of different physiological variables, such as different age groups. Overall, research reports minimal evidence to suggest that blood levels of S100B outperforms emergency evaluations of TBI by trained practitioners when it comes to acute recommendations for treatment or further intervention. So again, if you're utilizing this to determine the next clinical steps in intervention, or whether or not a scan is needed, this assay does not outperform that of trained clinicians. The fact that elevations of this protein in samples may be reflective of factors beyond just brain injury, that physical issues that don't involve TBI can result in elevations, and that more specific assays correlated exclusively with TBI have been developed, well, that's what has limited the use of S100B in the US. And as mentioned, it's not among the current FDA-approved biomarkers. That may change over time with further discoveries, but that's the status as of the case of this presentation. Now, there are currently 2 blood biomarkers that have received FDA approval for ruling out intracranial injury. glial fibrillary acidic protein, or GFAP, is the first that we'll review. In 2018, the FDA authorized a blood test for clinical use in the diagnosis of mild TBI, that is the Banyan brain trauma indicator, we'll talk about in just a moment. And the substance measured in that test is GFAP. This is a substance that is indicative of damage to astrocytes. Now, again, astrocytes play a critical role in maintaining the health and the homeostasis of neurons. Astrocytes are largely responsible for building and maintaining the blood-brain barrier. They have the capacity to upregulate or downregulate blood flow to the neurons, so they are providing both the catalytic oxygen to the cells to create energy as well as the nutrients. They are regulating that flow to the neurons. They can also directly influence neuronal firing to make a neuron more or less likely to fire. So they serve many very important functions. When astrocytes are damaged, there's a cascade of events that results in damage to the cells that they support. Again, if an astrocyte is supporting a neuron, and then that astrocyte is damaged, then that neuron is going to be likely degraded in functioning as well. And again, you're talking with these graphics, as we generally are when we're talking about the brain, it is way so oversimplified just to make it even possible to look at it. You're talking about millions and millions of astrocytes that can be supporting a given cell. So it is the way in which those support functions degrade that then can cause a secondary process of damage or the potential of cell death to a neuron, something that is called apoptosis, secondary to metabolic or ionic disruption. The astrocytes regulate the environment around the neuron. And so when astrocytic function is disrupted, this can result in excitotoxicity and metabolic stress and in inflammatory processes. It's basically a loss of all the support needed for a neuron to be healthy and an increase in the toxicity of that immediate environment. So damage to the brain results in an increase of GFAP secondary to damage to the astrocyte. And this can be detected within the bloodstream. We've done that presentation previously on the glymphatic system and how waste products are flushed out of the brain, eventually to wind up within the lymphatic system, and then it goes into the blood system. So that's how that chain of events occurs. Now, this can be detective. GFAP can be detective in the bloodstream. It's typically detectable within the first hour after an injury. It peaks at around 20 hours, and it remains elevated for 24 to 48 hours. The most reliable detection window begins about 30 to 60 minutes post-injury, and there's some evidence that there's a measurable rise as soon as 15 minutes post-injury. The second substance that has met FDA approval is that of ubiquitin carboxy-terminal hydrolase L1. That is a mouthful. Hope you'll forgive me if I'm just going to call it UCHL1 from here out. UCHL1 is a neuronal protein that is in high abundance within the neurons of the central nervous system, and it is involved with the processing of ubiquitin. Ubiquitin is a central process that is basically essential for neuronal health, synaptic function, and protein quality control. Not just neurons, but all the cells of our body. That's why it gets its name. It is a substance that is everywhere that cells are throughout the body, and that is everywhere, and not just human cells. It is present in most tissues that have cells with a membrane-bound nucleus. So any animal or plant you can think of is absolutely full of ubiquitin because it is considered to be ubiquitous through such cells. It contributes to the balanced pool of functional proteins in the neuron, and disruption contributes to neurodegenerative disease. When a neuron is damaged, ubiquitin is released into the bloodstream in an amount that is proportional to the amount of damage sustained. So again, this is a scalable release of a substance that is in every cell in the body, but particularly this one is in the um, neurons themselves and in the cell body's nucleus. UHCl1 shows a profile of elevation that's measurable typically within 30 minutes after an injury. It peaks at around 8 hours post-injury, and then declines over the next 24 to 48 hours. Studies indicate that elevated levels of UCHL1 correlate with injury severity and may predict incomplete recovery even when CT does not reveal any evidence of an intracranial insult. And someone had asked about the spelling on astrocyte. Depending on where I find a really good image, sometimes they are British and therefore have a slightly different spelling. And again, UCHL1 is elevated typically within 30 minutes after injury. It peaks at around 8 hours post-injury and then declines over the next 24 to 48 hours. Now, the first blood test that was previously mentioned as approved in 2018, a standard measure of GFAP, was the Banyan Brain Trauma Indicator. It was developed by Banyan Biomarkers and established the regulatory and clinical basis for a TBI biomarker by measuring both GFAP and UCHL1. The criteria established by the research that's put out here shown what their process was. That established the initial investigation that opened the door for the development of assays by different companies to include GFAP and UCHL1 in their range of lab-based tests that are offered. Now, this particular study was published in the journal The Lancet Neurology, and it reported a high sensitivity. Out of all the patients studied, those who had radiological indicators of injury on their CT scan were correctly identified by criterial levels of the blood biomarkers at an accuracy rate of 97.5 to 97.6. If the blood test values for GFAP and UCHL1 were below the criteria level, there was a 99.6% certainty that the patient did not have an intracranial lesion on a CT scan. That specificity measure showed that positive results were found in 36.4 to 36.6 of the cases when no lesioning was observed on CT, indicating that micro-level cellular damage was detectable that CT did not pick up. Now, these results suggest that the exceptionally high negative predictive value, that 99.6 value, meant that if the blood values were below criteria, one could safely rule out the need for CT scans in those cases. The results also suggested that although only 6 to 7% of the entire cohort of subjects had injuries severe enough to show up on a CT scan, 66% of those patients had positive results. They had elevated levels of those proteins. This demonstrates that the test is highly sensitive to cellular level concussion damage that standard imagery fails to identify. Question came up, could UCHL1 be elevated with any non-CNS trauma? There are the potentials for other neurodegenerative processes to show elevations of those levels, which emphasizes the need for corroboration with other clinical observations. In other words, if you have someone who has been identified with a specific type of neurodegenerative process, then that would confound and potentially complicate the interpretation of that blood biomarker data for an elderly patient, for example, with diagnosis of dementia. UCHL1 levels, again, reach their peaks earlier than GFAP, and the combination of UCHL1 and GFAP in the blood meet the recommendation for FDA approval of diagnostic accuracy over a full 12-hour FDA window. The regulatory requirement that GFAP and UCHL1 may only be used to aid in CT decision making in adults, not children, but in adults, who present within 12 hours of a suspected mild TBI or concussion, as we've said. So that is the FDA approval. It is for adults who present within 12 hours of a suspected brain injury. The instruments that you see on this slide are the Abbott iStat. It's a handheld blood analyzer, and it's a point-of-care instrument that can provide results in around 15 minutes for TBI-related testing. So this device requires 2 to 3 drops of whole blood, and the device then handles internal calibration, reviews the specimen, and displays the results. It can wirelessly transmit or download that data to an EMR. Abbott also has a high-throughput automated central lab immunoassay machine called the Alinity that is also FDA approved. Now, there are other machines put out by other manufacturers, but I'm talking about the Abbott equipment as representative of the type of technology that is currently in active implementation. Typically, a negative combined GFAP of less than 65 picograms per milliliter and UCHL1 level of less than 360 picograms per milliliter. Those are the criteria. Those two levels, if it's below those two levels, it would be associated with an absence of intracranial lesions on CT and therefore supports deferring CT in low-risk patients. I actually had to look it up. Picogram, believe it or not, is 1/1,000,000th of a gram. So that is an amazing degree of specificity. What that means is there are going to be levels of both of these substances within the bloodstream because they are within the brain of any human being. But they are at relatively low levels, and when those levels go up, it is indicative of a potential traumatic brain injury. Again, combining this with observation and also self-report and all of the clinical things that you would normally do to try and identify the severity of a patient's injury. So just to recap, for these tests to be utilized reliably, they're intended for individuals over 18 with suspected mild TBI. Samples have to be collected within 12 hours of injury and also with a GCS of 13 or greater, which is redundant with saying it has to be a mild TBI because that's one of the ways that we quantify mild TBI, GCS 13 or greater. Another lab device that received FDA clearance in 2024 is the VITAS TBI. It's a GFAP and UCHL1 test by a French company, Biomarker. And this device produces results in around 40 minutes. And this is typically for a clinic, hospital, or large lab-based type services. Other lab-based service companies that currently offer GFAP plasma tests include LabCorp and Quest Diagnostic. And then Hospital Core Labs is a company that offers a dual marker panel testing for GFAP and UCHL1. There are undoubtedly going to be many more medical devices in development that will reach the market over time because of the utility of this process. Now, the clear boxes in this graphic, primarily along the bottom there, those are the labels of different cellular components in the brain, either components of a neuron or the support cells, the glial cells that provide some function to that neuron. And then the color boxes reflect the potential cellular substances that are currently being investigated as potential biomarkers of injury, and those that are specific to a given area, those that are for the neuronal cell as opposed to the synapse itself. Most tend to be associated with the cell body or the axons at this point. And again, a lot of it has been centered on the glial cells, particularly the astrocytes. So you can see that beyond the biomarkers that we've talked about that have been already FDA approved, there's a whole host of substances that are in various stages of investigation. So there's the potential for much more accurate diagnosis, either directly or through adjunctive measures. Combining multiple measures will likely be the best practice as we currently do with clinical observations and tests. It's beyond the scope of this presentation to go into any level of useful detail for all of these potential biomarkers listed, but just know that there's a tremendous amount of research currently underway to find what is the best and most accurate indicator or combination of indicators that can give us the best diagnostic or directing of how a case should be handled. Not just in the immediate aftermath of the injury, but also accurately predicting and anticipating the needs in a given case. There was a comment there. If there is a smaller window for detecting an injury, would LabCorp request really be the best way to send out testing that created delay in the result receipt? That is certainly an issue, and it's why those point of care devices are really getting a lot of attention right now, because that's when you really want the question answered. And I'll talk about how that applies to given legitimate cases as well. I do want to mention a couple of additional biomarkers that are not at this point FDA approved tests, but that show a lot of promise for at least as an adjunctive measure. One is neurofibrillary filament light, NFL. NFL is a protein found in the axons of neurons, and when neurons suffer damage or die, apoptosis, the death of a neuron, when that happens, NFL is released into the cerebral spinal fluid, cleared via the lymphatic system, and ends up in the bloodstream. As a result, measurement of this blood biomarker provides a quantification of axonal damage. NFL is one of the biomarkers that's being studied for the potential to predict long-term cognitive outcomes and to track slow or delayed physiological processes that occur long after a neurological insult. Now, one issue with NFL is that anything that causes damage to the axon results in elevations of this biomarker, so it's not exclusive to TBI. NFL has been called a barometer of axonal damage, but it's impacted not only by TBI, but also by the processes involved in the development of several different types of dementia, and by motor neuron diseases such as ALS or multiple sclerosis that actually impact the axon indirectly by damage to the oligodendrocyte, the cell, the glial cell that forms the sheath, myelin sheath around the axon. And then the other one listed would be tau. Tau is a protein that helps maintain the health and stability of axons. And in cases of injury or disease, it's released into the cerebral spinal fluid and again subsequently into the bloodstream. And like NFL, elevations of tau are present after TBI, but are also associated with other conditions of neurodegeneration and disease processes. Each of these substances, NFL and tau, measured after a TBI, give indications of the severity of injury and provide some adjunctive predictive measures of outcome. Now, given that the current indicators of the highest utility of this technology appears to be in the area of mild TBI, much of the anticipated use of blood biomarker information appears to be particularly applicable to certain settings. Prior to availability of these objective and quantifiable measures of neurological injury, diagnosis of mild TBI is relied on clinical observation. So in other words, observations that you can see from the sideline in a sporting event. There's a collision and the individual does not immediately get up or gets up and then falls down or comes to the sideline confused. Those observations are the current hallmarks of a brain injury after a mechanically plausible event has occurred with the potential to occur such an injury. Again, think full speed collision on a ball field or the type of physical collisions that are common to football, to soccer, to hockey, or to other sports. The current sideline tests, balance tests, ocular observations, cognitive screens, these can miss subtle signs. So blood biomarkers offer a minimally invasive means of providing objective evidence of TBI, a quantification of neurotrauma in the form of astrocytic injury, neuronal injury, or related axonal damage. In many cases, neuronal insults are progressive in nature and may not initially present with their full scope or they can be masked by other physical issues in the immediate time frame after the injury. Blood biomarkers can provide early detection of highly specific factors that can identify and quantify the severity of an injury. This provides valuable information and recommendations for the next step. There's also the potential of developing guidelines for serial assessment that can assist in contributing to tracking recovery and improved return to play safety. The presence of devices that can provide rapid and on-the-sideline assays can assist in determining the need for imaging or more comprehensive emergency evaluation, or could rule out the need for unnecessary scans. In sports where there's a risk of cumulative exposure to repeated concussive or subclinical impacts, serial testing can provide profiles that may help differentiate secondary injury progression from stabilization and recovery. This helps identify athletes who may be at greater risk for long-term neurodegenerative changes. Question there, wonder if the Abbott handheld device is equally as reliable as a lab study and how pricey the handheld device is. I do not have answers to either of those questions, but I would assume that those larger lab-based machines would typically have a slightly different error rate than something that, but I don't know that to be the case. So again, when I say I don't know and then go on to answer a question, you should just discount anything that I say after that. That's what I tell my interns. Okay, military setting. This is another spot where it makes a lot of sense to have this type of rapid testing. The availability of rapid results from military field diagnosis is a huge benefit to distinguish mild, manageable TBIs from more serious injuries in the early phase. By ruling out intracranial bleeding in the field, it adds valuable decision making relative to the need for hazardous or expensive evacuations to higher levels of care. Due to the high sensitivity of blood biomarker testing, it's an ideal means of identifying whether a given blast exposure has caused neurotrauma. There are currently ongoing studies at Walter Reed Army Institute of Research to see how these blood biomarkers can assist in the prediction of the likelihood of long-term neurodegeneration or lingering post-concussive symptoms in veterans. And this is useful in acute clinical settings. The Orlando Health Orlando Regional Medical Center was reportedly the first hospital in the world to implement the bedside whole blood test for TBI. Again, the primary utilization of this blood biomarker testing in this setting is to rule out unnecessary CT scans. A recent statement based on data from the University of Florida, in one of the reports I read, said, and this is a quote, "There is currently no publicly available exact count of the total number of facilities utilizing blood biomarker testing for traumatic brain injury. However, with FDA clearances expanding, hundreds of hospitals, U.S. trauma centers, and military bases are actively adopting these rapid assays." Close quote. Additionally, from conferences that I have attended over the last year or two, there's a lot of talk of professional sports adopting this technology as well, even at a college level. Sideline testing to make better decision making for return to play or the need for more in-depth medical workup. Now, given the current nature of blood biomarkers for TBI that lie primarily within the range of mild TBI, the application at this time from the standpoint of rehabilitation are mainly an objective way to track neurobiological brain recovery after injury. Rather than relying on subjective symptom reporting, serial testing can monitor levels of various blood biomarkers and help identify at-risk players, soldiers, prevent premature return to activity, and reduce the risk of secondary injuries. Now, down the road and with further research, it's hoped that these objective measures can also help guide targeted rehab strategies based on physiological recovery, can monitor issues of neurodegeneration, and when combined with other clinical observations, provide more accurate predictive algorithms for determining prognosis. Again, it's hoped that more information on the back end can be used early on in early assessment of TBI. Now, as with any technology, there are limitations and complications, and given how early all this is, there is certainly a lot that are associated with blood biomarker research as well. It brings tremendous promise to accurate objective quantification of brain injury, but we have to be aware of what limitations do exist. Within the current literature, one is the varied timing of biomarker presentations and peaks. Some are detectable soon after injury and then decrease. Others are slower to peak and remain detectable for greater periods of time. So selection of the right blood assay and the interpretation of the results has to take those varied time frames into account. There are inconsistent cutoff values for some of the different assays that are being studied. And you can get different results across different platforms or even for specific populations. This complicates interpretation of results, and it'll be a limitation until more research provides greater standardization and equivalency data. Given the recency of this technology, it's not yet adopted across all the environments where its use can be beneficial. The vast majority of concussion diagnosis and quantification of injury relies on clinical observations and will continue to. But with the implementation of this technology, it's most likely going to be found again in, major sports leagues, high-profile medical or military facilities, and then that widespread adoption will follow, hopefully. There's currently, and this is huge, given that concussion is across all ages and disproportionately affects a younger population. There's currently limited pediatric implementation. The FDA clearance is currently only for that at or above the age of 18. So research to expand these guidelines to a younger population will be necessary to benefit the vast number of injuries that occur in the under 18 population. Now, the most logical first step is deployment, getting this technology into all the different settings that we've talked about, particularly where the greatest benefit is to occur in EDs, in urgent care clinics, and medical practices, where those sustaining concussion are likely to first seek treatment. As mentioned in limitations, a much needed step and one in which research is ongoing would be to expand the age group to pediatric patients, given the high incidence of concussions in this population. Most of the pediatric-focused population research has been within the last 10 years, as opposed to adult research, which goes back over 20 years. The standardization of protocols this is addressed as a critical barrier across studies. Standardization in sampling protocols, sample handling, analytic platforms, and data interpretation, all of this limits the ability to compare across studies and to establish much-needed universal diagnostic thresholds. And then multimodal assessment. This refers to the use of biochemical markers, advanced neuroimaging, AI-based predictive modeling. All of these can potentially result in identifying risks, in monitoring injury and recovery progression, and creating individualized therapeutic interventions, all which can be developed, certainly as we have more blood markers to work with. Further central nervous system specific metabolic symbols identification is needed relative to the metabolic response to trauma, the ability to differentiate these signals in the presence of polytrauma, which again is often the case in more serious injuries. And the last one to address is time. Again, the recency of these discoveries means that there's a very limited number of large-scale longitudinal studies. So to utilize this data in determining predictions and prognosis, we're going to have to have large multi-center longitudinal data to address that need, and that can only be achieved with time. Basically, we know more now than we did, and we know less than we will. So the development and use of biomarkers in TBI provides promising initial utility and the potential to affect aspects of more severe injuries in the future. So here are the takeaways that I want everybody to feel like they have heard today. Blood biomarkers can provide objective measures of brain injury, particularly helpful in cases of mild TBI where you don't otherwise have an objective means of measuring those things that aren't picked up on some of the other aspects of what we normally do to identify a concussion or a mild TBI. The current use is primarily to rule out radiological imaging when it is not needed. I can see its potential in use for a lot of other aspects as well, but that is right now what it is FDA approved for. TBI biomarkers may improve accuracy in identifying those who may have poorer outcomes. Again, this is going to be dependent upon more longitudinal studies, are greater implementation within all of the different avenues that we have talked about this being useful in. With wider implementation and more research, we're going to learn a lot more. So this certainly has a great deal of potential. Time will tell the degree to which it will live up to that potential. So at this point, I will switch over here. Here are all the references. The handouts will be available so that all of that will be there for you. This is my direct contact information if you want to get in touch with me. Um, email is probably the best way most of the time if you have other questions. So Don, you can jump in at any time, but I'm going to kind of go through some of the questions that were laid out here. Is there any blood testing after a month has passed since the insult? That is going to be a mixed answer of yes, there are elevations that do last for a significantly long time after injury, but no, none of them are currently FDA approved, and it is still in a place of investigation. Quick reference guide that lays each of these out time frames would be nice. Yep, but that is, you're right. You said that that may change. It definitely will change with more research because that standardization is something that right now continues to be a point of contention. If we have somebody that's been admitted to the ER hospital and a head injury is suspected, can we request this testing be done? Again, it would depend on the one thing that you don't have control over, which is whether or not that facility has adopted this at this point. Again, it is new enough that it is probably the larger trauma centers at this point that have access to these. For other cases, maybe not necessarily point of care testing would be available, but the old-fashioned send it to the lab and wait for the results could very well be the case in those instances. And I just wanted to share that there are brain donation programs that exist for study postmortem to learn more about TBI and CTE in various populations, including specific victims of domestic violence. The one I am aware of is Mount Sinai. Just wanted to share that out. Yeah, thank you very much for sharing that. That is certainly the case for doing postmortem investigation, that those donation centers do exist. So I thank you all very much for your attention throughout. Don, if you want to unmute and jump in for any announcements at the end, now would be the time.
Excellent. Jeff, thank you so much for this really interesting topic. It sounds like there's a lot to be done and a lot more to be studied.
That is truly the case. It's what you get at the end of every dissertation I've ever read as well. So this somebody other than me needs to take the mantle on and take this further. So, yep.
Excellent. All right. Looking ahead, September 16th will be our next webinar. Topic is post-concussion disorder and the vagus nerve. Jeff Snell will be the presenter for that. We're going to take August off, back to school and vacations. And with that, I think we'll wrap things up. When you leave the webinar, a pop-up will occur and you'll have a chance to fill out a jot form survey for today's presentation. And when you hit submit, you will automatically receive the certificate and the slides. And if you don't, that means that your computer blocked the pop-up. So please email us at qlibwebinars@qliomaha.com and enjoy the rest of your day. And Jeff, thank you so much.
And Don, thank you. What a marvelous job you have done hosting today. So thank you for doing that. Appreciate it.
There was no poll question today. It's going to be the survey when you leave well, people are already filling out their surveys. All right, we're going to wrap things up. Thanks, everybody.
Thank you, Don.